Ryan Stanton here with ACEP Frontline, and today we're talking with Dr. Deb Fletcher, a friend of mine for years now, and we're actually talking about a hot topic, and that's scope of practice. And of course, in states across the country, there's always a whack-a-mole with regard to expanded scope and misinformation and thoughts about what it is going to do, what it doesn't do, that sort of thing. And so for you, this is something you've been passionate about. Of course, being in a place that's been a hotbed for dealing with it anyway, so you've had the hammer out whacking the moles more than about anybody. So kind of give us a background about how you got passionate and interested in this.
Well, in 2019, I didn't even really know anything about scope. I was just working, going home, enjoyed being a mom part-time. And another company took over our group, and they decided to replace the part-time doctors with non-physicians. Mm-hmm. So I was told that my job wouldn't be needed anymore, which was a little perplexing. So I started Googling it and researching it. I emailed Sandy Schneider, who had been past president, and she emailed me back within 5 minutes. And we had a really good conversation. At the same time, ACEP was doing their workforce study, and I really got to know all of the things that were going on right now that I didn't have any idea. That nurse practitioners had already gotten full independent practice in a number of states at that time. And then some PAs groups were going for it. So it opened my eyes.
And we've recently, with my group, we're looking at a contract, and our cost is higher because we are a very physician, all board certified, heavy model. And at most, it's a one-to-one physician supervision model, as opposed to any type of expansion. What we see is still a lot of times is one physician. Basically, they're just air traffic control with the non-physician seeing all the patients and managing everything. And the challenge is, what I've found is that if we give up or willing to give up anything, somebody's willing to take it, and then yes. You have to fight to get it back. We can ask the anesthesiologist about that because they've had their own fights with this as well. So kind of give us the landscape of what we're seeing out there right now, because I think when I came down last and talked in Louisiana, we're still talking about that point, the potential of pharmacists starting to do some evaluation and prescribing themselves. So a lot of different things out there in landscaping, from the physician's assistants to nurse practitioners to pharmacy to a lot of different things out there, and it's a little bit different in each state.
It is. And right now, nurse practitioners, they're the big ones. They have the largest lobby, and they have a bunch of groups who help them. I think 27 states have passed that now. PAs want to get in on the competition, so there's a number of states that have given them independent practice. Mm-hmm. Pharmacists, because their corporate groups, I think, would like the money. They want to be able to order tests, interpret the test, prescribe, all from their pharmacy. And most pharmacists I know really don't need that extra headache because they're already overworked filling prescriptions. The interesting one we have this session in Louisiana is an audiology bill. And if you read it, the audiologists are baseline just wanting to be able to do hearing aids without a physician. But there were some really sneaky little things in there. One of them said that they wanted to be able to handle vestibular symptoms without a physician's referral. Mm-hmm. And I know the worst thing I can get in an ED is dizziness, because that's everybody's system. I mean, neuro, cardiac, GI, ENT. So they're just going to go ahead and take on dizziness on their own. So those are, you just don't know who thinks that they have the capabilities to do these things, and they don't.
And I think there's a huge gap in understanding, one, having the kind of physician role of wanting some of that, but without a lot of the responsibility, the malpractice, the legal, the undifferentiated dizziness, that may be a posterior circulation stroke, and not simply just a vestibular issue and need, something that needs the Epley maneuver. There's a lot of complicated things, and so there's a fight to get the piece of the pie, but without having to put it together, bake it, pay for the ingredients and the potential risks of eating it. So, kind of from your experience of looking at this, what are some of the kind of arguments for and some of the gaps that you're seeing in terms of understanding what comes with this truly happening?
Part of, I think, what they have on their side is the lack of access to care, to primary care and to specialists. So they see the fact that they could come in and do this as a benefit. So many patients can't even get to a physician. I see that on paper, and if that were true, if they would go into rural primary care, that'd be fantastic. But even the states that have already given full practice authority to nurse practitioners, you do not see anybody extra really go in rural areas. The AMA has maps and density maps for all states. I can see it, in all of them, and it doesn't change. Look at Florida. They passed 3 years ago a law that said they could only do primary care independently. No other specialty care or anything. It had to do primary care. And recently we've kind of figured out they're not just doing primary care. If you call some offices, they may be an aesthetic practice, or they may be a psych NP practice. So they're skirting the law, but we have to get it out there with data. So those are extra studies to work on. I think that they can help a lot of people, but then they don't know their deficiencies. They don't know what they don't know. So if they worked with a primary care physician, or even in an emergency department, one-to-one, where they could get really good education, that would help.
Yeah, absolutely. I mean, you mentioned the aesthetics aspect of it. That is proliferated exponentially, especially in my community. It seems like kind of the end goal for many to get into this. So it's very interesting how that tends to happen. Where do you see us moving forward? Because this is a major advocacy point for the American College of Emergency Physicians. It's been against independent practice, physician-led team, understanding there is a key role for nurse practitioners and PAs in our healthcare system, but understanding it is within that healthcare system and physician-led team, not as an independent entity,
Right.
as there is definite differences in the training experience, exposure, and really that ability to kind of break down that differential diagnosis. To kind of look forward into saying, what are the opportunities now that we're starting to see a lot more data and research that shows that passing this legislation does not increase access to care, does not increase primary care. Basically at this point what we're doing is just kind of creating another complexity and potentially, confusion among the public in terms of who they're seeing, the qualifications they're seeing, and the training that you're seeing. I mean, what I'm seeing now is when patients come in and say, I just saw my doctor today, and looking at the primary care and who they saw, and it was not a physician. Kind of looking at looking glass of where this is kind of progressing, and where as physicians we need to continue to fight for it.
A couple of things on that. Transparency laws, like passed in New Jersey, we really need to do that to protect the patients, because they don't know, like you said, they thought they saw a doctor, but if it wasn't transparent, they don't know who actually they saw. So we need transparency laws with signage at the location of service where they could see who they're seeing, who that person's, if they have a collaborator, what's the name of the collaborator, what specialty is the collaborator, and what state they're located in. That can work in any clinic. It can work in the emergency department. It could work in a rural emergency department. But they need the knowledge to know, because that's their decision. They should have to possibly do informed consent to see a nurse practitioner and say, I agree that this is not the high tier level of care, but this is what you've got, and I'll do informed consent. They need to know. I think laws on staffing ratios would be good to have, like we're working on this with ACEP, possibly one-to-one. If the physician is seeing their own patient, if the physician is not, maybe 1-to-2. So it wouldn't be a spoke system where the physician is getting overwhelmed and unable to supervise correctly. That can also be done in states that have already passed independent practice and go at the hospital bylaws level and put some guardrails and say, this is what we want our staffing ratios to be. So there's a number of things we can still do, and it just takes everyone getting involved.
And that's you mentioned the overwhelmed physician. The idea behind ACEP, the physician-led team, is the physician has the opportunity to see and be directly involved with every single patient. If we have too many spokes on that wheel, as you kind of put it, there's just no way you're actually going to be able to get engaged to know about each particular patient to the depth of which you need to see those or know about those patients.
Correct.
It becomes incredibly difficult, and I think that's one of the things that with the ED accreditation that's just getting rolled out is part of that transparency plan. Who are you seeing when you see that red sign out there? The patients, when they see a red sign, need to know that they have access to an emergency physician. So, kind of as you wrap up, it seems like I can always get some good information from Louisiana with interesting interpretations of independent practice. Any other examples or just things that you want folks out there to know?
I know in Louisiana we have a lot of rural hospitals. I worked in some of the rural hospitals. They're lovely. The patients are fantastic. You've got fantastic nurses. And just getting to know the patients out there, you shouldn't let them have poor care just based on their zip code if they don't have a physician out there for them. And I do know, unfortunately, some of the locums and contract people will put a physician out there who may not even be the best physician. So the hospital needs to work at that level with the contract group. I'm sorry, we're not taking that person who's a cardiac anesthesiologist and won't teach you. But we're also not going to take a nurse practitioner because they may not be able to do all that we need them to do. So they can improve the strength at the hospital level and make it safe for their community, because they have to answer to the people in their community.
And we have to, and even out there protecting nurse practitioners and PAs, others, getting in those situations very often just simply graduating and going to areas with an expectation to potentially practice independently and not having the experience, skill set, education, information, and getting in a difficult situation. I hate to see somebody fresh in their career lose their career because of being put in a very dangerous situation. For us as physicians, we don't get to graduate med school and immediately go out and run an emergency department. We have to go and get our 16, 18, 20,000 hours of patient contact and then, take a test, a multiple test, that says you can actually do this independently. I think that's the biggest challenge, is understanding that there is something that is different about board certification in emergency medicine with regard to the practice to emergency medicine. And I think there's other strategies out there in terms of getting access, improved access, but it's not simply opening up the floodgates and thinking that the water's going to go down the right pathway. If you think that's going to take place. How can folks get in touch with you if they have any questions, comments, or thoughts?
My email works at ddfletcher, FLETCHER, at mindspring.com.
All right. Appreciate you. Thank you for your time. It's always great seeing you.
You too.
And always enjoy my time in Louisiana. I know we were telling stories with Luke earlier about his review of restaurants with me.
Yes.
And there's always good stuff down there.
It is. And we're going to try to have another CME event, new CME crawl in November. So Louisiana's the fun place to be.
It is an incredible place. And honestly, when we do our foods and motorsports, it's hands down. People ask me where's the best food, and I said anywhere other. If you name anything other than New Orleans and Louisiana in terms of food, there's so much great stuff there. But I do appreciate your time and the invites, opportunities to come down and work with your chapter. So as for me, you can contact me, rstan@acep.org, rstan@acep.org, at Everyday Men on X. Make sure that you're subscribed to the podcast. And until next time, I'm Dr. Ryan Stanton. This has been some ACEP Frontline. All right, one thing we missed out on, we forgot. There is a great study, Hattiesburg Study, that we're going to put a link in the show notes. It's going to be in there. Yeah, it's 2022. I'm getting cues over here. This is like real TV. All right, so it's 2022. There's a study we're going to have in the show notes. Check it out. Some great information on this topic. So scope expansion, scope of practice, study, show notes. Do it.